What I wanted to do was start off with a couple of thank yous. And the first one happens to be Dan and his team for allowing us to convene a panel of folks who've been able to today distill a whole lot of information into some themes that the reactor panel just identified. It's been really great to do this. So thank you, those of you who are in the panel who developed and who developed this and all the speakers, and Dan and your team for helping us to do this. Thank you. So what I'm not going to do now is go and revisit a slide that I showed at the beginning about lessons that we hoped to be able to address during this presentation. But as I go through that list myself, I feel pretty confident that were we to have the time to go through and unpack each one of these, I think we'd see some examples of how these things can actually be implemented in real life. And notwithstanding the fact that some of them are very clearly not plug and play, and that there's a whole continuum of applicability to low and middle income countries, from the last panel, I think I'm heartened that at least some of the concepts can be translated in ways that are productive in terms of transforming healthcare. So again, I won't go through all these in detail, but I think they're important. One thing, though, we did not address, we tried to make this actually fairly concrete to show you real examples, Project ECHO, South Central, Cambridge Health Alliance, organizations that had put this into play, and to stay away from theory and frameworks, which are easy to manipulate, and at the end of the day, you don't get very much. But a question that might arise is whether or not there are any simple common frameworks to help guide transformation, particularly at the service delivery level. So I'm not talking about the health system level writ large, but for each, whether it's a practice or a health center or a solo practitioner's office, if you're trying to move into some of the kinds of models of care that we described, advanced primary care was the term that Asaf used, medical homes, others, are there frameworks that would help one to do that? So I'm going to very briefly just try and seed your interest, S-E-E-D, your interest, to say that there actually are a couple of frameworks that might be useful. Shoma Stout mentioned in her Cambridge Health Alliance presentation that we and some others had worked with them to implement this medical home model or the transformed primary care model. That was in the context of a Commonwealth Fund-sponsored initiative called the Safety Net Medical Home Initiative. And in that initiative, we conducted some analyses of a variety of transformation efforts like the ones that we heard about today, and tried to develop some fairly simple change concepts. We did this in collaboration with Ed Wagner and his team at the McCall Center, the McCall Institute for Healthcare Innovation, the Group Health Cooperative. And literally, as we speak, Ed is receiving an award at the Patient-Centered Primary Care Collaborative in Washington, D.C. for that and similar work to help understand and actually transform primary care through means such as this and the chronic care model, which you may be familiar with. So, not wanting to go into detail, let me just say that behind each of these change concepts, there are a number of kind of tactics and techniques that have proven to be successful. I don't think actually too many of the other groups that we heard of today specifically use this. It has been used actually in several environments. I'll show you a couple later. But we actually think there's a little bit of a sequence. Notwithstanding the discussion earlier, and I take Sanjeev's point about leadership in some contexts, countries maybe not being the place to start. Clearly in clinical practice, having a foundation of some leader in the practice or the system is a prerequisite for things getting done. Some of these things can kind of bubble up from the bottom for a while, but there needs to be things. What Donna did not, she talked about the board, but she didn't point out, for instance, that South Central has had a visionary CEO for much of its history who has been a leader in that practice, maybe not the government people outside, the funders and things like that, but that kind of leadership is important, as it is in a two-person practice where the two doctors haven't even really talked to each other, had a meeting for the 7 years that they've worked together, not an uncommon situation. Someone really does have to have some leadership capacity. Now, we talked about quality improvement in a variety of ways, but many of these systems have developed can only succeed because they have a quality improvement strategy, which includes a method to create change and a means of understanding whether or not it's effective. We heard that from several folks, from the Community Health Center perspective, from South Central, from Cambridge Health Alliance and others. So having a good leadership structure and a means to move change forward is really critical, we think. We talk about population health. We think that actually starts with defining a population, having a panel. Many of the innovations that we heard today, ranging from, at the Omada technology approach, which had a population actually that's trying to impact, to community health centers, to others, have a defined population and really define a relationship between a patient and a provider and his or her team. So that's something that's really important because it's tough to develop relationships without an understanding of who you're developing a relationship with. Particularly if you want to work proactively as opposed to reactively when they come into the door. Donna described her initial experience of people coming in. If they had a cough, you took care of the cough. If they had a sore throat, you took care of the sore throat. You can do that without having a panel because people come in and they're reactive. But if you really want to do population health, you need to focus on empanelment. And then you're able to have these continuous team-based healing relationships. We heard a lot about teams today. Unpacking this would illuminate a whole bunch of things that you heard examples of today, but teams need to be there. We heard of specific methods of improving care, having registries, having case management for people with complex conditions, stratifying populations, a variety of evidence-based quality improvement approaches in addition to providing evidence-based medical care, giving people the treatments that they need, withholding those that they don't, and not misusing medical care as well. So there's a whole focus on being able to provide organized evidence-based care. We heard a great example in Project ECHO of being clear about what are the big things we have to deal with, what are the conditions, and then being very clear, and sometimes it requires external specialty expertise to get to that evidence-based care. Sometimes it's something that is intrinsic to the primary care practice. They don't need some outside help, but they need to focus on that. Patient-centered interactions, we've heard over and over again today in every context that relationships were the important things. They're the secret sauce. Whether it's the secret sauce in the Omada digital health thing that's really all on computers, or whether it's the customer owner position of South Central, or whether it's relationships between patients, providers, specialists, and others in various Project ECHO models. That's patient-centered interaction, self-management. I think Carol Heyman pointed out that self-management is one of the critical components that's really been associated with improvement in outcomes of people with chronic illness. If they don't manage their own care, and the 99% of the time they're not in the physician's office, they're not going to get very much better. Finally, enhanced access, getting people the care when they need it, where they want it, and eventually coordinated care amongst various systems. That turns out to be a somewhat complex situation that actually does require a well-functioning team, an understanding who the panel is, a quality improvement methodology to make sure that you can close loops and really make sure I think Darren Anderson was saying when he looked at the proportion of completed referrals before they instituted an e-consult system, it was 35% of referrals that were actually made from the practice ended up with the full cycle being completed and the referral being accomplished to a specialist, and then the data coming back to the primary care provider. To fix that requires a fair amount of infrastructure to be in place. So that's one model. We've used it in that SafeNet Medical Home Initiative, 65 very diverse practices from homeless clinics to rural health centers to academic health centers to residency training programs. In the Harvard Medical School Academic Innovation Collaborative, 20 Harvard-affiliated facilities did that as well. And lots of other places, both in the US and other places as well, other countries have used this kind of model. It's not the only one. This is a model that was developed by Tom Bodenheimer and his colleagues at UCSF. But if you look at it carefully, I'm not going to give you quite time now, many of the same elements, starting off with engaged leadership, having data-driven improvement, empaneling patients, team-based care. These are the themes that I heard, at least today, emerge. And frankly, I found more alignment than I even expected to hear, that people told the same story over and over again. It's very consistent with these models. Now, the last thing I want to close with is the fact that some things happen quickly and some not so much. Some of the systems we've heard today are fairly new. They've been around for 4 or 5 years, and they're doing pretty well. Some it's taken them literally decades to transform. This is a little bit complicated. I'm not going to go through it, but just to say, if you use a framework like the one we showed, and you intentionally work at small steps and provide tools to people. This happens to be every 6 months. If you look at the very right-hand set of bars where they're going up, it's every 6 months on a series of assessments based on implementation of that Safety Net Medical Home Initiative framework that I showed you. People can actually, when they attend to it, make incremental change. But it takes years and years for for especially established systems really to transform in a way that looks like South Central, Cambridge Health Alliance, Group Health Cooperative, Community Health Center. And that's something also that we've noticed that, at least domestically, funders don't always get. They want things done in a year or two and think that changing the reimbursement mechanism and then doing an evaluation study will have huge impacts on outcomes and quality of care in 2 years. It doesn't happen. And the Centers for Medicare and Medicare Innovation has a predecessor organization that has a long history of failed experiments in many parts because they were really too short to allow systems really to transform. So with that, I will thank you all for attending, and thanks for coming today.